Thanks, Tarek. Thank you, Mark. And thanks to all of you for inviting me to give the 2016 Founders Award lecture. I have no financial disclosures. So the Founders Award, this is an award in honor of the founding members of the Vitreous Society, which was established in 1982, Gerald Bovino, Roy Levitt, and Alan Verne. Later, the society became the American Society of Retina Specialists, of which all of you are members. This is the largest and, I believe, the most progressive retina society in America, and I'm happy to be a member. I would like to share with you what I've learned over the past few decades on innovations in retinal tumors. I like to call it alphabet soup. It's alphabet soup, and I think you'll find out soon when I show you how we term these tumors. Sometimes when you look at alphabet soup, you might see ABC, you might find words like help or swag or win. And this is our retina tumor alphabet soup. And if I shift the letters around, you'll see what I mean. These are the tumors we deal with on a day-to-day basis, sort of like alphabet soup, standing for different tumor names like astrocytic hamartoma, retinoblastoma, etc. So in this short time, I'm just going to give you a quick update on what's going on with astrocytic hamartoma, retinoblastoma, capillary hemangioma, otherwise known as hemangioblastoma, and then the RPE tumors. So let's first ladle out astrocytic hamartoma. Now, I know you know how to identify this as a calcified or non-calcified retinal mass. This usually occurs in the nerve fiber layer, sometimes or always. Always. And it causes mild retinal traction, and it's often associated with TSC, tuberous sclerosis complex. So now I ask you, retinal specialists, name another fundus finding in TSC. And I think most of you will scratch your head and say, I really don't know. Well, here, I'll show you the finding. Can you see it? Right there, and there, and there. This is known as the retina achromic patch of TSC. Some people call this RPE punched out lesions. Better seen on fluorescein angiography as window defect. We use this finding to clinch the diagnosis of TSC. It is such a strong finding for that diagnosis. Here we see a patient with 2 retina achromic patches in an eye that has 3 astrocytic hamartomas. We looked at this retina achromic patch, or otherwise known as RPE punched out depigmentation in eyes with TSC. And we indicated in that Archives of Ophthalmology article that the most common eye finding in TSC is the retinal astrocytic hamartoma. And this retina achromic patch is really not clearly understood and not well known. And some people feel it's a flat astrocytic tumor, but we really don't think it is that. We think it's simply RPE depigmentation for some reason. And we looked at 56 patients with this finding and found that we looked at 56 patients with TSC and found the retina achromic patch in 21% of cases, significantly associated with increased number of astrocytic hamartomas, peripheral location of astrocytic hamartomas, and cognitive impairment and seizures in patients with TSC. So I ask you another question. Does the retinal astrocytic hamartoma or the achromic patch have a systemic correlation? Like, does it imply a worse prognosis or an ominous finding? And the answer is yes. So again, you as retina specialists, if you see one of these 2 findings, you better look in the brain in these patients. So Mary Aronow from Cleveland Clinic did a nice analysis where she looked at over 900 cases from the TSC Alliance and over 100 cases from the Cleveland Clinic TSC program. She found patients with TSC, 35% have astrocytic hamartoma, and 12% have the achromic patch. And if a patient had either of those lesions, they were at risk for brain astrocytoma, renal angiomyolipoma, cognitive impairment, and seizures. Again, a retina finding implying systemic problem. So keep that in mind when you see these patients. Another question, in what layer does the astrocytic hamartoma arise? The nerve fiber layer, always. We didn't really know this until we had spectral domain OCT, and Pichi et al. From Italy was the first to publish on that, always in the nerve fiber layer. He looked at 43 cases and proposed a classification based on that. And in a parallel study, we looked at our cases, and we found that retinal astrocytic hamartoma arises in the nerve fiber layer in 100% of cases, and it shows a very typical appearance on SDOCT, a moth-eaten appearance in over 90% of cases. In an analysis of 47 eyes, we found this. You can see the two different cases, retinal astrocytic hamartomas, and here you can see the nerve fiber layer expansion with this tumor and the moth-eaten appearance, giving these optically lucent cavities, which represent either a cavity in the tumor or calcification. Moving on to our next tumor, retinoblastoma. There has been so much progress with retinoblastoma, you can't believe it, in the past 10 years. So the four of us from 4 different centers around the world got together and published in JAMA Ophthalmology Agreement and Disagreement. Chantada from Buenos Aires, Munier from Lausanne, me from the city of brotherly love, and Dave Abramson from the Big Apple. And in this collaborative effort, we indicated we agree and we disagree, but there is a trend towards localized treatment with intra-arterial chemotherapy worldwide. This is the most successfully treated pediatric cancer, and it's targeted chemotherapy that we're using. Hardly ever do we use radiotherapy for retinoblastoma anymore. We use intravenous, intra-arterial, subtenons, and intravitreal chemotherapy. And when do we use it? We use intravenous chemotherapy for bilateral retinoblastoma, intra-arterial for unilateral retinoblastoma, intravitreal for vitreous seeds. We don't use subtenons anymore, too much complication and fibrosis. And for high-risk eyes, we give systemic chemotherapy. It's an art and a science. It's not just a recipe. So here's what intravenous chemotherapy looks like in a child with bilateral multifocal retinoblastoma, 3 agents, 6 cycles, chemotherapy given, tumor regression, macula returns. And we confirm this on OCT. Intra-arterial chemotherapy is used for unilateral retinoblastoma. We mark the forehead, we indicate M and T, the medications we're going to use, and the dose we're going to use. We send the patient to the neurosurgeon who catheterizes up through the ophthalmic artery and gives a dose of chemotherapy into the ophthalmic artery, or actually goes up into the internal carotid, occludes it, and gives the chemotherapy into the ophthalmic artery. Here's some examples, but first I'm going to show you a head-to-head comparison, comparing intravenous chemotherapy to intra-arterial chemotherapy for unilateral retinoblastoma. This was published in the Asia-Pacific Journal of Ophthalmology just a few weeks ago. Looking at intravenous, we get good control for groups B, C, and D, seen in the yellow columns, but you'll see with intra-arterial for unilateral retinoblastoma, we get control in nearly every case for B, C, and group D. In fact, significantly better control for group D. So now it is our drug of choice, our approach of choice for unilateral advanced retinoblastoma. So here's a group D eye, massive disease, only a little bit of retina visible superiorly. We give intra-arterial 2 doses, the tumors completely regress to a calcified scar, and the retina's flat. We even use this in young infants. This child, 60 days old, we catheterize the ophthalmic artery to treat this tumor, provide this regression, and only 2 doses of chemotherapy was used. And we even use it for our older patients, but this requires excellent skills in catheterization by a neurosurgeon or an interventional neuroradiologist. Here's an older patient who was 32 years old. He developed late-onset retinoblastoma. You can see the tumor inferior to the macula here. He received intraarterial chemotherapy, regression of the tumor, but I do have to admit he required more therapy with plaque radiotherapy and intravitreal chemotherapy, but we were still able to save the eye and his vision. There are complications with intraarterial chemotherapy. You should know the complications. It can cause ischemia to the retina, but also we're using a very dangerous drug, melphalan. This is a nitrogen mustard alkylating agent that can cause pancytopenia and leukemia. We've not yet seen that. And it can also cause male infertility if more than 7 doses are given. So we limit our number of doses to 3 or 4. Now, as part of my Founders Award, we will be publishing on this topic, rhegmatogenous retinal detachment following intraarterial chemotherapy for retinoblastoma. We have found that we're treating more and more advanced eyes, and about 6% of the eyes that we treat develop a rhegmatogenous retinal detachment. It's related to retinoblastoma in older kids with very advanced diffuse infiltrating disease and vitreous seeding. How does it happen? It happens because the tumor has infiltrated the retina and destroyed the retina to such a degree that when we give the chemo, the retina is left with gaping holes. And often there's more than one retinal hole. As shown in this case, you can see on your left the diffuse infiltrating retinoblastoma, and then after treatment with intraarterial chemotherapy, multifocal gaping atrophic holes. And in another advanced case on the left, following intraarterial chemotherapy, 3 side-by-side atrophic holes. These are very difficult to treat, and we're only successful in fixing the retina in about 50% of cases. I'll say just a few words about capillary hemangioma, otherwise known as hemangioblastoma. I know you know how to identify this as a red-orange retinal mass with feeder vessels and exudative retinopathy. If a patient has 2 or more of these lesions, by definition, they have von Hippel-Lindau disease. We've learned a lot from Wang et al. At the NIH in collaboration with Emily Chu about the clinical features of retinal hemangioblastoma in patients with VHL. He did a really nice study and found that poor vision in these cases is related to older age, juxtapapillary tumor location, increasing number of tumors, and increasing tumor size. And he actually provided a really nice table where he looked at the odds ratio for poor vision. And he found that poor vision was related to juxtapapillary location. Comparing that to peripheral tumor, there was a 2.8 times greater risk for poor vision. And if you look at patients who had 5 or more tumors compared to those with less than 5 tumors, an 8 times greater risk for poor vision. And if you look at patients who have more than 1 quadrant of retinal hemangioblastoma versus less than 1 quadrant, there's a 26 times greater risk for poor vision. So the clinical features do correlate with the risk for poor vision. Here's a patient who might have good vision, a peripheral tumor, solitary. We were involving 1 quadrant, and we were able to treat that with PDT, our treatment of choice. And that tumor received 1 session of PDT, showed a little bit of a hemorrhagic result, but the exudate resolved. In other cases where we have more extensive subretinal fluid, we'll use radiotherapy. Our preference is plaque radiotherapy, treating the tumor, and you'll see that the tumor involutes, becomes fibrotic, and the exudative detachment resolves. Sometimes you can't even see the hemangioblastoma. This is a case that we shared with Lee Jampal from Chicago. Can you find the tumor? This child has VHL mutation. If you look very carefully, you can see the tumor. And if you image this child, you can see the tumor, and then on fluorescein angiography, and then on OCT. We can catch these tumors now super early using multimodal imaging, and we wrote this up in a case of twins where the tumors were invisible but found on multimodal imaging with super early detection. But don't forget, in addition to the eye, these patients are at risk for systemic problems. VHL patients are at risk for brain hemangioblastoma and renal cell carcinoma and pheochromocytoma. The first tumor to occur in VHL patients is the retinal tumor, so it'll be up to you to identify it and then get them sent for testing. The average life survival in VHL patients is 50 years. They die from the brain tumor or the kidney tumor. So it's important to have other consultants involved in their care. And there is a genotype-phenotype correlation with VHL. Patients who have type 1 VHL tend to have a deletion and pheochromocytoma is absent, whereas those who have the less common type 2 mutation, which is a missense mutation, are at risk for pheochromocytoma, so you can anticipate it. I think the future of retinal hemangioblastoma will be targeted therapy. Here I show you the HIF pathway, hypoxia-inducible factor pathway, which is the pathway that leads to all the tumors with von Hippel-Lindau. If we could target this pathway with Sutent or sirolimus, which we are using now, we might be able to resolve some of these multifocal tumors. I'll say just a few words about solitary circumscribed retinal astrocytic proliferation. When you see this, it's an amazing little tumor that occurs in the fundus, in the retina. It's a pearl white retinal mass. Jerry Shields was the first to publish on this in 7 cases, and we've now had more experience. It looks like an astrocytic hamartoma or maybe a retinoblastoma, but none of those tumors look this pearl white. And we used to think this arose in the nerve fiber layer, but until we had SDOCT, we were wrong. Astrocytic hamartoma arises in the nerve fiber layer. Solitary circumscribed retinal astrocytic proliferation arises deep to the retina. We published this in the journal Retina. You can see the astrocytic hamartoma superficially with a cavitation and the scrap deep in the retina. And if you look at it on the OCT, that's the tumor. We think it might even be arising from the RPE and draping the retina overlying it. This was published in 4 cases along with Richard Rowe and Larry Iannuzzi in the journal Retina. Lastly, let's talk about some of the interesting RPE tumors. And I'll limit this to just 4 of these tumors: Chirpy, combined hamartoma, congenital simple hamartoma, and torpedo maculopathy. Chirpy, I know, is a very common tumor, fairly easy to diagnose as a flat black mass in the fundus. It can show enlargement in over 80% of cases. It is a low-grade neoplasm. It grows. And it can develop adenoma or adenocarcinoma in less than 1% of cases. The top panel shows enlargement. The middle panel shows an enlargement of lacunae. And the bottom panel shows development of adenoma. So keep that in mind. It's important to monitor these patients yearly. We've learned about the OCT of Chirpy. Adrian Fung looked at 18 cases, and he found that Chirpy is a very abrupt lesion. The whole outer retina is affected at the site of Chirpy, hence you get a visual field abnormality. You can see the abrupt margin, that's a blood vessel. Here you can see the lacunae with transmission of light through the lacunae. Here we can see photoreceptor loss, and then a cleft where the retina is retracted, and then the abrupt margin with the normal choroid outside and posterior to the Chirpy. Combined hamartoma has a completely different OCT appearance. Arapelli et al. From our group published on 8 cases and showed this can be associated with NF2, brachiocephalic clefting syndrome, and Potter syndrome, and it can have a mini-peak or a maxi-peak vitreoretinal traction appearance. Mini-peak sort of looks like a sawtooth pattern where the retina is pulled by the vitreous adhesion. Maxi-peak is where the retina is actually folded from extensive vitreoretinal traction, and sometimes there's a combination of both on OCT. The group from Bascom Palmer has shown that if you have NF2 and you have a combined hamartoma / epiretinal membrane, you're at risk for brain tumor. So keep that in mind if you see this in a patient with NF2. Congenital simple hamartoma, there's not much to say about this. This is a very quiet little tumor that sits in the macular region, appears like a black ink dot, and has a classic OCT pattern of abrupt elevation and abrupt shadowing. We don't know what layer this tumor is in. It generally remains stable and does not cause visual problems. And last but not least, I'd like to talk about torpedo maculopathy. Maybe this is a little overemphasized in the literature. It's congenital, usually depigmented, temporal to the fovea, vision is usually good, and it has no systemic associations. Well, not until 6 months ago. We think it's related to developmental abnormality during embryogenesis of the eye at the site of the fetal cleft. You can read this article in JAMA Ophthalmology to understand how it develops. So on the upper right, I show our report. On the bottom right, another case from Wills from the pediatric department, and on the bottom left, a case from UCSF. You see the similarity. It looks like a torpedo heading to the fovea, but patients generally have good vision. The team from Chicago, under the direction of Lee Jampal, has looked at autofluorescence, completely dark, and OCT showing the cleft. But you know that clefts are seen with torpedo maculopathy, chirpy, and we even see them overlying some choroidal nevi. The last point I want to make, we used to think torpedo maculopathy was unassociated with systemic disease, but a report came out recently on torpedo-like maculopathy with a systemic condition. This looks like torpedo. This is the face of this child with microcephaly. And this is in a child with Zika virus infection. And in that series, they showed that torpedo-like maculopathy, temporal to the fovea, occurs in these kids. In their series, 4 of 6 eyes had torpedo-like maculopathy. So we've looked at the alphabet soup over the past 20 minutes. Hopefully I've given you some new tips and pearls on some of the new things going on with ocular oncology and retinal tumors. It's all about alphabet soup. I hope you have learned a lot. And I'd like to thank our founders, Jerry Bovino, Roy Levitt, and Alan Verne, for establishing this society and allowing me to provide this lecture. Thank you.
Carol, that was an amazing, amazing talk, and wonderful photos. Hopefully you'll share some of those with us on the retina imaging bank. I see Suber in the front row. He manages that, so such beautiful photos. Any questions for Carol? While people are coming up, I had a question. For the retinoblastomas, there's a reduction in the radiotherapy. You showed such wonderful results with the melphalan intraarterial. How apart do those 2 doses need to be, given the systemic side effects? How do you wait a few days, a week, a month?
Yeah, so the interval is usually 1 month. That allows enough time for the patients to have the slight pancytopenia recover. So we've not had anyone have leukemia or permanent pancytopenia. It's usually a little drop in the blood count. And we're very careful with this. In our practice, we still use a lot of intravenous chemotherapy because in some ways it's a little bit safer than intraarterial chemotherapy. We're not catheterizing into the brain of a baby. But the beauty of intraarterial chemotherapy is it is quick and it is powerful. So if we have a really advanced eye or an eye that has failed other standard treatments, we can usually clean up the eye with intraarterial chemotherapy. It's been a real, and I give Kaneko and I even give Dave Abramson credit for being pioneers in this field. We've done a lot of it in Philadelphia. It's pretty much caught on around the world. The only thing it is a expensive treatment, so most developing countries don't have access to this. We have a program at Wills where we take in children from developing countries for a very low fee, and if it's their only eye, we'll salvage the eye for them.
Thank you. So any other questions from the audience? I don't see anyone else. It's kind of bright. So anyway, thank you for that wonderful lecture.
Thanks, Mark.
Absolutely.
Appreciate it.
Okay. All right.
I'll just stand over here.
And I'll present you this beautiful award, the Founders Lecture, with your name on it and the name of the founders. It's a great pleasure again to have you and give you this award. So.
Thank you. I'll turn around this way.
Oh, and no award is complete without a check. Here's your check.
you.
All right, okay.